Very good afternoon and a very warm welcome to NITRD, CTB and National Task Force Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome Padma Awardee Dr. Behra Sir, our DDG Sir, Dr. R.P. Joshi, Dr. Rajendra Prasad Sir, Bharadwaj Sir, Dr. V.M. Katoj Sir, Dr. Sachdeva Sir, all the state TB officers, directors of STDC, directors and team from NIT and NTI, faculty of medical colleges, district TB officer, medical officers and others, a very warm welcome. To start with introducing the faculty from NITRD, I am Dr. Neeta Singla, Nodal Officer DRTB Center at NITRD. On my right is Dr. Rupak Singla, he is head of the Department TB and Respiratory. On my left is Dr. Amitesh Gupta. He is a pulmonologist at NITRD. Now I would request our director, Dr. R.K. Diwan sir, to give his introductory remarks. I think Dr. Diwan is taking time joining the session. So we'll invite him once he joins us. Meanwhile, we have our DDG sir, Dr. R.P. Joshi. Sir, we welcome you and we would request you to give your address.
Thank you, madam. Good morning, all. Rather, good afternoon, all. So, firstly, I'm very thankful for being part of this very important meeting. See, we are using technology to communicate with all our officers and experts, so that any doubts, any scientific doubts, any clarifications, our experts can guide the team, and it will also be useful for the discussion on the case. Will also be useful for all of us, because it is a learning process where we also learn from observing others, what doubts were raised and what I would have done if the same case was handled by me. So this is a very, very important initiative, and I am grateful to all the faculty members and those who are organizing it and taking time to find out a difficult case, collect all the information and make it a teaching experience for all the participants. So once again, thank you all, and wishing the meeting a grand success. Thank you.
Thank you very much, sir. Dr. Diwan has been able to join us now. I think there were some technical issues. Dr. Diwan, sir, you're there?
I'm there. Hello.
Welcome, Dr. Diwan. We request you to give your introductory address.
Actually, there was something issue with the net. That's why I could not join on the computer. I'm joining through the phone. It's like as Joshi is on the move and he has delivered this lecture, we are on the move and can do these meetings now. I think how many people have joined, Dr. Nita,
so we
so far
have
today?
about 165 people.
165 people have joined. And we have a very interesting case lined up today also. And as you, I welcome all the delegates who have joined, senior faculty members and the National Task Force chairperson, the experts, and senior people. Has Dr. Katoj also joined, Dr. Nita?
Not as yet, sir. We had a message, we had a message that he'll be joining a bit later.
We'll also, Dr. Katoj, the senior most person amongst us and who has been the Director General ICMR and held several important positions in Government of India and in the profession, is also likely to join us and give us our blessings. As usual, our head of the department, respiratory medicine, Dr. Singla, has joined already, and several experts from across the country. Today's case, we will all be watching with a lot of interest. As usual, our meeting has generated a lot of interest, and the cases which are discussed are of quite high standard. I look forward to joining myself also. Best wishes, all of you who have been worked hard to arrange it. Best wishes, Dr. Neeta. Go ahead, please. Thank you.
Thank you very much, sir. Thank you for supporting us all the time. Thank you so much. Now, moving on to today's case presentation. In the current series where we are inviting the states by rotation to share their difficult case from their own state echoes, giving us all an opportunity to learn from their experiences. So in these sessions, we have an expert from the state and then we have national expert. Today's session is from state of Uttarakhand, and AIMS Rishikesh will be presenting the case. We are waiting for STU Uttarakhand to join Dr. S.K. Jha. Is Dr. S.K. Jha there? So we'll invite Dr. Jha once he joins us, who will inform us about the echo activities being taken in their state. So meanwhile, we move on to our presentation. The presenter for today's case is Dr. Ajish KP. He's Senior Resident Department of Pulmonary Medicine at AIMS Rishikesh. And the expert for the case from the state is Dr. Ruchi Dua. She's Additional Professor, Department of Pulmonary Medicine at AIMS Rishikesh. The national expert for the case will be Dr. D. Behra, sir. Sir needs no introduction. He's a Padma awardee and he's currently Emeritus Professor of Pulmonary Medicine at PGI Chandigarh, and he's also advisor to National Task Force. Welcome, Dr. Behra, sir. And over to Dr. Ajish for his presentation.
Thank you, ma'am. A very good afternoon to all of you. I will proceed with my case. So, today I am presenting the case of a 49-year-old gentleman who is residing in Sambhal district of Uttar Pradesh, who is a sweet vendor by occupation and is a reformed smoker and tobacco chewer.
Sorry to interrupt you, Dr. Ajish. Can you put it on the presentation mode?
Yeah.
Slide is not moving also.
Give me a minute, ma'am.
You will be sharing you will see the new share button on your top of the screen. Just click on
New
it.
share. Okay.
And then select the first window where it is written as screen. And there will be a box. First box which is written as screen.
Pardon?
So when you click on new share, a dialog
Okay.
will appear and there will be a number of boxes, and then you have to select the first screen. It is written as screen, the box with your PPT.
Okay.
And then just share it.
Okay, I'm clicking my presentation and sharing it. Is it visible now?
I think you've got to do enable editing and maybe you can go to farm.
Okay.
You can reshare, maybe stop share and then maybe start all over again.
Okay. Okay.
Technical issues do happen, and every time we also learn something. So no issues at all, Dr. Ajish? Should we share on your behalf if you're facing some issue?
Is it visible, ma'am?
It's not visible.
Just
अभी
one second.
एनजीओ में काम कर रहा है
Yeah. Just one second. This one.
This one.
That's one.
Please bear with us. No issues at all. We'll just take 2 seconds. Yeah. You can see the slides now. Just put it on. Dr. Ruchi, I think ये आपकी slides आ गई हैं.
Yes, ma'am. Just one second. We're just
Yeah.
trying to change. Just otherwise, you can share the slides from there.
Yeah.
Rajesh can present. Is that okay?
Sure, we can do that.
Yeah. Yeah.
Okay, so we are sharing now.
Thank you, ma'am.
Okay. Yeah, go ahead.
So, next slide. Okay. So this is the case is regarding a 49-year-old gentleman who is residing in Sambhal district of Uttar Pradesh, who is a sweet vendor by occupation, and he is a reformed smoker and reformed tobacco chewer. Next slide. who had been referred from END OPD to our OPD as part of pre-evaluation, as he presented in their OPD with an ulcerative growth in oral cavity, which they clinically diagnosed as carcinoma buccal mucosa. And with the plan for surgery, they have referred to our OPD for pre-op clearance, as the patient was a case of MDR-TB on shorter injection containing MDR-TB regimen since 11th of January. And patient, when presented to our OPD, had complained of grade 2 dyspnea, productive cough, intermittent fever, and streaky hemoptysis, which he had reported since past 1.5 years. Next slide. He doesn't have any comorbidities. Next slide. So his past TB history is as follows. He had history of TB 7 years back, which was microbiologically confirmed according to the patient history, and pulmonary tuberculosis, and he took ATT from private setup for 6 months and symptomatically improved, and post treatment he was asymptomatic for 4.5 years. Then he had recurrence of symptoms 1.5 years back with fever, productive cough, hemoptysis, loss of appetite and weight. Then again, he was diagnosed as microbiologically confirmed recurrent pulmonary tuberculosis, and he again took second course of ATT from private setup for 11 months. Both of this treatment doesn't have any records available with the patient. There was, but even after the 11 months of treatment, patient didn't have any improvement in symptom. Hence, patient reported to the government setup in Sambhal district. Next slide. So he subsequently visited the TB center at Sambhal and was initiated on drug sensitive ATT as his sputum AFB was positive, and they started evaluation for drug resistance. Then his sputum CBNAT, which was sent on November 25th of 2021, came positive for MTB, and rifampicin resistance was detected. And based on CBNAT report, he was initiated on shorter injection containing MDR-TB regimen from 11th of January. His first line LPA was sent on 1st of February 2022, and it came as rifampicin resistance detected and isoniazid resistance, high level resistance detected. His next slide. His LPA report is as follows. We can see that the rifampicin RPOB locus mutations were present, and also CATG mutations were present, but INHA mutations were absent. So rifampicin resistance with high level resistance to INH was confirmed with LPA. Next slide. Okay. So his shorter regimen consisted of kanamycin 750 milligram, moxifloxacin high dose 600 milligram, ethionamide 500 milligram, clofazimine 100 milligram, ethambutol 800 milligram, pyrazinamide 1250 milligram, and high dose isoniazid 600 milligram, and pyridoxine 100 milligram, which is according to his weight of 45 kg. Next slide. On examination at the time, he had submandibular lymphadenopathy suggestive of nodal spread of his buccal carcinoma. Next. Next slide. Vitals were stable on presentation. Next. And his physical examination, especially respiratory system, confirmed bilateral, showed clinical findings suggestive of bilateral disease. Next slide. Rest of the system examination were normal. Next. So investigations, his baseline investigations. This is the X-ray when he presented to our setup. It showed bilateral infiltrates, more in bilateral upper zone and left mid zone, and left predominant disease we can see. Next. His CT was done. Next. It also showed evidence of active disease in the form of thick wall cavitary lesions with surrounding consolidation, as well as tree bud pattern and sequelae of previous tubercular infection. Next. So his second line LPA, which was reported on 25th of February 2022, reported fluoroquinolone resistance both to GAIR-A and GAIR-B with inferred resistance to second line injectable drug. Following this second LPA report, patient was initiated on all oral longer regimen from March 10th of 2022, which consisted of bedaquiline, linezolid, levofloxacin, cycloserine, and clofazimine, according to the 45 kg weight band. Am I audible, ma'am?
Okay, Ajish, you are very clear.
Okay.
Yes, yes, you are audible. You are audible.
Next slide. So, patient became sputum AFB positive on November 25th, and that is the time when patient approached the government NTEP system. Then he was started briefly for 20 days for drug sensitive TB regimen. Then his sputum CBNAT report came on 7th of December, and based on that rifampicin resistance, he was started on shorter injectable MDR regimen. He was initiated, and then his first line LPA was reported on February 25th, in which high level resistance to INH and low level resistance was not detected, and was also confirmed. In second line, then his second line LPA report came on February 25th, in which fluoroquinolone resistance as well as second line injectable resistance was detected, and he was diagnosed as pre-XDR and all oral regimen was started. His liquid culture DST report is yet awaited. Next slide. So the final diagnosis is CA buccal mucosa. His histopathological examination later came as poorly differentiated squamous cell carcinoma with a clinical stage of T3N1M0 stage 3A, which is very well amenable for operation. And according to the margins and the nodal spread status, he is a candidate for he will be a candidate for chemotherapy as well as local radiotherapy. Along with he had recurrent PTB, which is pre-XDR TB, and he is on longer oral regimen since 10th of March 2022. And following this, with this diagnosis, actually we discussed the case in our state level echo forum, and we advised modification of the regimen, although they didn't completely changed according to our format. It had been discussed in their state level dots plus center, and he was currently on delaminate, cycloserine, levofloxacin, clofazimine, linezolid, and bedaquiline. This is the current treatment status of this patient. His liquid culture DST is yet to be procured. Next slide. So during this course with the altered regimen, he is symptomatically better. He is febrile. Cough and expectoration has reduced. Although his weight hadn't shown any improvement, weight is still static around 45 kg only. But radiologically, we can see there is at least there is no progression of the disease, and there is discernible resolution of airspace opacities also. Next slide. So now the current plan for is CA buccal mucosa, poorly differentiated squamous cell carcinoma is surgery followed by possible chemotherapy and radiotherapy. Okay. Now the further part of the discussion will be carried forward by Ruchi madam. I hand over the.
Dr. Ajish, thank you so much for a very nice presentation. So before we go for next discussion on the case, I would like to welcome Dr. Rajendra Prasad sir, who has just joined us, Dr. Jaikishan sir, and Dr. S.K. Jha, STO Uttarakhand. STO Uttarakhand, Dr. Jha sir will be inviting you at the end of discussion to take your remarks from the stage. So now we will be discussing this case. Basically, this is the people who have joined little late. This is the case of oral cavity carcinoma. There is a squamous cell carcinoma, and patient has been simultaneously diagnosed as a pulmonary TB, that is DRTB pre-XDR. The issue that is to be discussed is how to manage DRTB and carcinoma together. So we have two experts today. Experts from the state is Dr. Ruchi Dua, who is the additional professor at AIMS Rishikesh, and we have Dr. Behra, our national expert. Sir has a very vast experience of managing cancers. So we'll be hearing from both of them. Over to you, Dr. Ruchi, for your discussion.
Thank you,
If there
ma'am.
if there are any questions on the history of the case, we could take them before we go for discussion. So if anybody, yeah, Dr. Rishi, you wanted to ask them.
Yeah, madam, this case is a very interesting case because patient is having MDR-TB plus grade 3 squamous cell carcinoma of the buccal cavity. Now, since the patient is having the carcinoma stage 3, so for and the treatment of this MDR will be going for say 18 to 20 months, long term or short regimen or long regimen. My concern is if during the follow-up, can we also do the PET scan to see the any follow-up cases of metastasis in the buccal in the left cervical area and in the lungs also?
Right, sir. So we'll take up that question when we go to management. So Dr. Ruchi and Dr. Behra sir will be answering your queries after they discuss what we hear them. I think your point will be covered there. And there are questions coming up in the chat. Why LEVO was given when patient was already diagnosed as pre-XDR? So Dr. Ruchi or Dr. Ajish, could you take that question?
His second line LPA had shown fluoroquinolone resistance. So, and inferred resistance to second line injectable. As fluoroquinolone resistance has been proved, we have to categorize the patient as pre-XDR, while his linezolid and bedaquiline status is not known since the liquid culture DST report is still awaited.
Why LEVO? You see, the
In the
question,
last,
the question here what has been asked is in case it is documented levofloxacin resistance. So why in the regimen the levofloxacin was retained?
sir, actually, this case belongs to the patient is belonging to a state of Uttar Pradesh, and actually we are not the primary team which is responsible. So we have communicated to the team, and according to them, the patient hasn't turned up for a follow-up. So they had the plan of stopping levofloxacin, but the patient has not yet gone to the center. Actually, that's the issue. And the first line LP only came by the end of February. So the last regimen has been changed in March, and unfortunately, the patient didn't go for follow-up. But as per discussion with the team, they said that they were planning to stop levofloxacin. We actually clarified it this morning itself. Yeah.
Yeah, actually in such cases, once the LP reports levofloxacin resistance, and nowadays based on the mutation pattern, we come to know whether high dose moxi can be given or not. So that is one thing. But also simultaneously, it is very important that we should put the liquid culture and DST to reconfirm the LPA finding, because it is there in the LPA guidelines that even if LPA says moxi high dose sensitive, then the liquid culture DST may show it is resistance. And the Indian experience has shown almost 30 to 45% of cases, the high dose moxi is sensitive by LPA, maybe resistance by the liquid culture DST. So in that case, again, it makes the case that in this case, plus he has received moxi high dose as a part of injection at any regimen also. So in such cases, we can avoid levofloxacin once it is resistant on the levo, and we can look for the drugs from the replacement sequence, as has been done like that after. Okay.
Definitely, sir.
There are few more questions in the chat box.
the one question by Dr. Amit Rath is that why high dose isoniazid was given as it was high dose was resistant on LPA in the initial regimen?
Actually, the report came, the shorter MDR regimen was actually initiated before the LPA reports came. So that's the reason why the patient was actually not receiving this. And this is also a part of the discussion and what actually could have been changed in the patient's management.
You
So,
see, again, this is very frequently asked question that in case high dose INH is resistant in the shorter injection containing regimen, why INH is given? Actually, we need to understand it's a package of treatment. It's a package of 7 drugs which are given, and among them, drugs like in the injection containing regimen, the injection, clofazimine, levofloxacin, they are the key drugs. So, and the experience has shown that even if INH is resistant, it may not affect the final treatment outcome. So even in the cases who are otherwise INH resistant, whether low dose or high dose, and you give injection containing shorter regimen, it is expected to be effective. So it does not become a criteria for not giving the shorter injection containing. That also we have to remember. So in that case, you have to give 7 drugs, the whole 7 drugs, including high dose INH. That is the recommendation of the national guidelines. Thank you, sir. Sir, in context of this, there is one more question. That is, like in this case, should one wait for the second line LPA? Like in this case, the second line LPA came after 1 month, or whether they should start with shorter MDR regimen to rule out FQ and SLA. You see, that is again another very important thing which has been raised. As per program guidelines, once a patient is diagnosed as DIF resistance or MDR-TB, the first option is to start the shorter injection containing or oral regimen for the patient, provided there are no contraindications. But here, the second LP report was not available. And not only that, if you see, the LP was sent after 2 months after the CMNET report. So these delays, I'll come to it again in the discussion part. But what I am saying is, unless the second-hand LPA shows FQ is sensitive, we should not be given a shorter when ideally speaking. Ideally speaking, if the report is not there, better to start on the all or longer regimen rather than shorter regimen, because FQ resistance is one of the major contraindications we start on shorter regimen. And in case we start on shorter regimen, we must ensure that the sample goes for the second-hand LPA, and we must ensure that the report is collected within time. Otherwise, we will be giving the inappropriate regimen to the patient. We'll come about this when we finish the discussion. Again, these delays.
Go ahead with the discussion then. So, Dr. Ruchi, we will take your discussion now.
thank you, ma'am. Thank you, Ajish, for a lucid presentation. So I'm just going to quickly first summarize the case and then discuss what are the main problem areas associated with this case. So this was a case of microbiologically confirmed case, initially started on drug susceptible regimen before the NAT report came.
Sorry, Dr. Ruchi, your slides are not moving.
Just 1 second. Should I stop and share again, ma'am?
Yeah, yes.
Is it visible now, ma'am?
The slides are visible, but I think they're not changing. Can you change the slide?
Yeah. Are the changes visible, ma'am?
No.
Ma'am, I just shared this text to Ajit on his WhatsApp. Can you just check it?
I'm sorry, I cannot hear exactly.
Dr. Ajish, can you check your WhatsApp? We have sent these steps. How to share.
How to share? I go stop share. New share. Yeah. Then screen.
Okay, Dr. Ruchi, we can see the slides. Perfect.
Is it visible, ma'am, now?
Yeah, it's visible and they're changing.
Okay, ma'am. Thank you, ma'am. So now it's not changing from here actually.
Okay, so
So
maybe,
it's better that you move the slideshow from there.
yeah,
I have
we
some
will,
animation
yeah. So you
also.
stop share, we'll,
Which was here.
Yeah. So
2 seconds. 2 seconds left.
okay, so till the time this technical glitch is taken care of, we'll take up one or two more questions.
Okay. There is one question in the chat box regarding the follow-up of CA oral cavity. That what was the status of progression of CA oral cavity during this when the patient was started on after the patient was started on TB treatment?
the patient is actually restaging procedure is needed only after 8 weeks approximately, and that is being done by the ENT department actually. So he would probably have to be restaged. It has already been a gap of almost 8 weeks, and he is yet posted at our center for surgery. So still being dated.
Okay, so the surgery is still not done.
Yeah.
Okay. So we are sharing the slides now. Yes, Dr.
Everyone, next slide, please. So this I have already told, and Ajish has also discussed. Yeah, please this slide. So what has been the case so far? This was a recurrent case. The patient was put on drug susceptible treatment before the NAT report. And we can see, as per the previous presentation, that the NAT took almost more than 10 days to come. So there was a long turnaround time for NAT. May I also tell that this case is actually registered at Uttar Pradesh and came to us during the course of treatment. So then next, the patient, after his NAT report came, he was started on a shorter injectable regimen. So before the second line LPA actually came. The first line LPA revealed a high dose of isoniazid resistance, and second line LPA, as already discussed by Ajay, showed fluoroquinolone and inferred resistance to second line injectable agent. So finally, this turned out to be a case of pre-XTR, and the liquid culture is still awaited. If you can just move the cursor, yeah. So one thing is very clear, there was a longer turnaround time of all the investigations. Can you please move it? Just the cursor once, yeah. And as of now, it is a pre-XTR case, though the liquid culture DST is still awaited. Next slide, please. So if we look at this, can you just keep on moving the cursor? Then I have some animations on the slide. So the patient was kept on shorter injectable MDR regimen for almost a period of 2 months, pending his LPA reports. So once we look at the LPA report, the second line injectable was already resistant. High dose H also was ineffective. Moxifloxacin low dose FQ resistance was documented, and as Singla sir already pointed out that the fluoroquinolone resistance cannot be exactly commented on, and patient had already received anti-tubercular treatment twice. So the efficacy of E and Z also becomes questionable. So at this time, probably the patient was receiving 2 or maximum 3 effective drugs. Can you just move on to the next slide? Yeah. So even if we look at the indications for the shorter regimens, the patient had extensive disease as per the CT scan. There was bilateral cavitatory lesions. Then the patient had received some unknown anti-tubercular treatment for the past 11 months. So we actually do not know whether he was exposed to the second line drugs or not. Obviously, at this time, the second line LPA had not arrived. So we could have probably best avoided the shorter regimen in this case. And as sir also said it, where we do not have the second line LPA, better to go for a longer regimen than to go for a failing shorter regimen, like in this case, both because of the higher turnaround time of the test, and here we could have probably used these two caveats to shift to a longer regimen. Next slide. So then the patient, once LPA reports came, the patient was shifted on a longer regimen which had these 5 drugs. Can you please move the cursor? Yeah. So out of these 5 drugs which were given to the patient, levofloxacin was, again, the patient was resistant to it, and because clofazimine had already been used for 2 months, its efficacy also was unclear. Meanwhile, the patient was taken up for discussion at the state level echo clinic, and as per the recommendation and discussion, we advised for a regimen change. The patient went back to the nodal DR center, and the low part of the slide shows a modified regimen which has finally been started end of March or beginning of April. It included delamanid, cycloserine, levofloxacin, which was controversial, and as we discussed personally with the treating team, they informed that they planned to stop levofloxacin, but actually the patient has not turned back to them. Clofazimine, linezolid, bedaquiline were all part of the regimen. The patient's weight was also at just the upper end of the weight band, which was almost 45 kgs. Adish already discussed that the histopathology has come in the last month, and it turned out to be a buccal cavity CA, a poorly differentiated squamous cell type. And the treating team has a plan for surgery followed by chemo and RT. So if we look at the regimen, there are 4 drugs probably which are proven efficacy: delamanid, bedaquiline, cycloserine, and linezolid, to which the patient has not been previously exposed. The liquid culture report is still as of now awaited, and we do not have its report yet. It wasn't found on the Niksha portal, and we could not get it from the team also. Next slide, please. Next slide, please. Yeah. So our concern in this case are 2. One is, has the management been done adequately, or any further change needs to be done? And second issue is pertaining to the management of CA buccal mucosa. The patient came to us primarily for a surgical clearance and clearance for chemotherapy and local RT, which was planned for his CA buccal cavity. Next slide. So I've just, in the next few slides, I've just put what evidence we could find regarding how to give clearance for cancer chemotherapy in a patient who has tuberculosis. And so there's a link between tuberculosis and malignancy is bidirectional. There is a higher risk of tuberculosis and malignancies because of common risk factors, because of the drugs which are used for the management of malignancy. Similarly, in any patient of tuberculosis with the presence of fibrotic scars, the risk of malignancy is higher, what we usually used to study as a scar carcinoma. Pertinent to this case is that because it was a head and neck CA, this itself is a predisposing condition for having tuberculosis. Next slide, please. So we can have 3 scenarios: that a patient on ATT is diagnosed with CA, whether lung carcinoma or whether any other malignancy. And this is what we have in our scenario, that a patient on anti-tubercular treatment was diagnosed with a CA. But interestingly, the patient is also a case of free XDR, and now we have the dilemma of whether how should we give a clearance for chemotherapy. Second scenario can be we have a concomitant diagnosis, and third is when a CA patient on treatment develops tuberculosis. So I've just kept a few studies, and it would be very good to have inputs from all the national experts. How should we proceed in this case? Next slide, please. So surgical clearance is very clear that usually in an emergent surgery, whether it is a drug susceptible case or a resistance case, usually we can proceed with the proper infection control guidelines. Though elective surgery, usually in a drug susceptible case, as per the 2005 guidelines, which is the last we could find, we usually have to wait for the smear conversion. That is a minimum duration of 2 weeks in a drug susceptible case. What about the cancer chemotherapy? Next slide. Next slide. So a few case reports where in pulmonary tuberculosis patients the prevalence of lung cancer has been seen, varied from 1 to 4%. Drug susceptibility testing was done only in a few cases, and most case reports show that it was a drug susceptible kind of tuberculosis. Most of the evidence we have is not level A at all. We only have case series or case reports. Next slide. This was a big study, more than 3,000 patients, only 38 patients with lung cancer and tuberculosis. No comment on sensitivity was done actually. Overall survival, the authors concluded, remains similar in both the groups. Next slide. Next slide, yeah. So if we look at the concurrent diagnosis, so this was one of the studies which we could find. Next slide, please. So as a part of this study, a retrospective study, 30 cancer patients were diagnosed with active tuberculosis. And as a part of this study, anti-tubercular treatment was given for 1.5 months prior to the anti-cancer chemotherapy. And the authors also said that if the tuberculosis was MDR, based on the sensitivity testing, it negated the initiation of anti-cancer chemotherapy. They said the success of ATT was 70%. There were no related failures, though there was a diagnostic delay and shorter overall survival in patients who had lung CA. Next slide, please. So concerns were, as a part of this study, there were no MDR patients. Only 2 patients with H resistance were there. The authors raised the concern if you're using rifampicin with some of the anti-cancer chemotherapy, because of the enzyme inducing action, you may have concerns. And they said that better choice would be a fluoroquinolone based regimen or other regimens without rifampicin, which is obviously not applicable in our case. Next slide. This was another study, 31 lung CA and patients who had tuberculosis and 51 controls who had lung cancer alone. In this study, which was published in the year 2020, again, drug susceptibility testing was not determined. Molecular testing was not used. Majority of the cases, as can be seen on the slide, 96% were new patients. The timing of ATT initiation was 54%, majority of the patient at the same time. In few cases preceded it, and few cases it was after the initiation of anti-cancer treatment. Next slide. So what the authors found was that the completion rate and the success rate in both the arms were similar. The median survival times were also similar. There was not much of change in the performance scores. The side effect profile also did not vary. And they concluded that patients with coexisting lung CA and active tuberculosis can safely receive both anti-cancer and anti-tubercular treatment. Next slide. Next slide. Yeah. So this was another study where we had patients of cancer and being followed up to see how many actually developed tuberculosis. So it was a retrospective case control study, more than 2,000 patients. First line ATT was started in all the patients. The frequency of completion of expected anti-tubercular chemotherapy was lower in patients who had both the disease condition, but it was not different after we exclude the loss due to progression of underlying malignancy. The authors said the bacteriological as well as the radiographic response to treatment and toxicity of anti-tubercular treatment were not different between both of the groups. Next slide. This was another study published in 2020. Next slide, please. So as a part of this study, there were 33 patients in group B who started chemotherapy less than 2 weeks of initiation of anti-tubercular treatment. 23 received chemotherapy after 2 weeks of anti-tubercular treatment was given. After 3 months, the author said that all patients achieved smear conversion and were better radiologically. The end of follow-up also observed no recurrence. So they say that little evidence exists on the optimum time of initiation of chemotherapy following ATT. 2 to 4 weeks appears to be a reasonable duration, but all this data is basically for a drug susceptible case. Concurrent chemotherapy and ATT seem to be both safe and feasible, though because most of the studies are a small sample size or are only none of them are an RCT, additional large-scale studies would probably be needed. Next slide, please. So we come again to the question that how should we clear the patient in a drug-resistant case of pulmonary tuberculosis? So for surgery, it practically should, emergent surgery especially, it should be similar to a drug-susceptible case. But what about if we have a case of MDR, pre-XDR or a XDR patient, like in this case? And when should anti-cancer chemotherapy be given? Like in our case, can it be given concurrently? Should we wait for a period of 6 weeks? Or it should only be after the sputum has converted? But one thing at least is clear, it should only be after initiation of effective chemotherapy, which in our case, without a liquid culture DST, is difficult to say. Next slide. So what answers do we have and what remains unanswered? So concurrent chemotherapy can be given after effective institution of anti-tubercular treatment, especially in a drug susceptible case, though the minimum duration after which it can be started remains unclear. Preferably after sputum conversion or a time of 2 weeks, which is the usual time when the smear may begin to convert. Surgery, obviously, if emergent, both drug susceptible or resistant, can be proceeded with infection control precautions. Next slide. So we come to the discussion points, and we would really be grateful to our national experts that first of all, has the patient been given an effective regimen? He is on a 4 drug to which he has been previously unexposed, so liquid culture is still pending. And secondly, when can we give clearance for chemotherapy in this case? Next slide. And a take-home lesson for all of us to suspect tuberculosis in all patients of malignancy and vice versa. Keep the high index of suspicion for both. Thank you so much, sir, for providing us with this opportunity.
Thank you, Dr. Ruchi. That was a very nice discussion, and you raised some very important questions, and you have answered many queries that we usually face in the field, because all of us at some point or the other face patients where they have malignancy along with pulmonary TB. Now I request Dr. Mehra sir to give his comments for the same.
So thank you, Dr. Nita and Ruchi. So good afternoon, everybody, Dr. Diwan and all others, and very clear. And Ruchi also discussed the case in the current context, in the proper context he told and raised many important queries. So I'll try to give my comments in two parts. The first one, I'll talk about the cancer and the TB, specifically MDR TB. And number two, of course, although she has also asked the question, I'll also like to give some comments about the management of his TB in this case, which Dr. Singla has already pointed out some points. Then, as we all know, cancer as such is a immunosuppressed state, and then tuberculosis is one of the the consequences because of this immunosuppression. It is not only cancer, it is also the type of therapy used, like the chemotherapy, any types of chemotherapy, the drugs which are used for treating various solid cancers. This one is taken as a solid cancer. In this case, they themselves also immunosuppressants, and they themselves also can lead on to flaring up of tuberculosis, development of tuberculosis like any other immunosuppressed states. So also is the radiotherapy. Wherever you give radiotherapy, there will be some degree of immunosuppression. So cancer itself, then the therapy itself, the chemotherapy as well as radiotherapy will be immunosuppressed states, and therefore chances of flaring up of TB will be obviously is a that will be a risky thing. So this is number one, and as it and secondly, the one more point which Ruchi also alluded to about the scar carcinoma part. Yes, that is a some people still believe scar carcinoma. It is usually a favorite discussion in when we talk about TB and cancer. But still, this is a very, I should say, it is a very controversial subject. So had it been the TB scar leading into lung cancer, then India should have been full of lung cancer. This is the negative. This is the flip side of it. But again, I am not trying to deny the development of lung cancer following TB. They may be coexistent also, independent to each other, because lung cancer can develop in a patient who has got already TB, because TB is so common. And the only thing about scar carcinoma is, say, it is the scleroderma associated, scars. They are more prone for developing lung cancer. But yes, any scar can cause, developing, that is a that can be a precondition for development of cancer. But in this case, it is a buccal mucosal cancer. So obviously, we are not talking of scar carcinoma in this case. But I think because it is immunosuppression. While the next about PET scan. Remember, the PET scan, it not only picks up or the FDG, which is the fluorodeoxyglucose, which is given and that is taken up by the malignant cells, but it can also be taken up by inflammatory tissues, like including tuberculosis, including sarcoidosis. So even if there are pulmonary lesions, so they will also take up the FDG glucose. So then you will be in a fix. What will be, some people say the, the points they give, whether it is a pickup is 7, 5, higher it is more, but the question is there is no cut off between the higher and the lower. It is take up means it is take up. So it can be either because of inflammation or because of cancer. So that is how it is always a problem. Even if we say, for example, it is a CA lung or any other cancer, and you do a PET scan and the mediastinal nodes pick up the the FDG. So then the question comes whether it is TB or whether it is metastasis. So therefore, many surgeons, they prefer to prove it, either through the mediastinoscopy or the bus or whatever way. So that is about the PET scan and its sensitivity and specificity. Now, how we should manage is cancer, and we should go ahead with the chemotherapy. Yes, chemotherapy can be given, but with only one, there will be two important issues associated with the cancer chemotherapy and the TB chemotherapy. As we know, many of the drugs, particularly in this case, it is either cisplatin containing or one of the platinum containing regimens will be given. So they produce a lot of side effects that we should know, like nausea, vomiting, diarrhea. So these are some of the very common symptoms of course, the other things like the blood cell, the cell counts, then the loss of hair or alopecia. So I'm just talking about which is pertinent to TB chemotherapy. There will be GI side effects, which are very, very common. So when we are giving drugs, and particularly in a drug resistant TB, the type of drugs we are giving. So if both things are given, the chances of getting side effects will be enormous. And we should be very careful, and we have faced that, particularly lung cancer patient when you give chemotherapy. But only saving point is that the cancer chemotherapy usually will be subsided within a period of about 7 to 10 days, whereas and then again you repeat it after 3 weeks or so. So it occurs about the initial 4, 5, 7 days, but be careful. So what precautions should be taken is the giving them the antiemetics. Now, very good antiemetics are available. The only thing, many antiemetics that includes also steroids, for short course of steroid is usually given for cancer chemotherapy, so that the patient does not have many of the side effects. So I'm sure one should be very careful not to give steroid. Usually for lung cancer chemotherapy and also other chemotherapy as a chemotherapy protocol, so they are given as the side drugs. So I think that can be avoided. Then number 2 also, then it is given the what we call omeprazole, pantoprazole, etc. are given. So as you know, some of these drugs are also to be avoided when you are giving drugs like bedaquiline. And then of course is the diarrhea. So, but question is, they can be given if the patient is and then for the cancer chemotherapy, for the antiemetics, we give now fosaprepitant, which is very good. So any one of the, whether it is any one of the other antiemetics, so they should be given judiciously when you are administering chemotherapy to a patient who is already on anti-TB drugs. So in my mind, they can be given, but with these precautions. The other issue is here I think you are given kanamycin. So if you are trying to give, of course now you are not giving, but I'm just trying to say some of the drugs like cisplatin or the platinum group of drugs, they had got also, the ototoxicity. So you be careful about that. Then some of these drugs are also, they produce the liver enzymes, raising of the liver enzymes, sometimes the disturbance of the urea and the creatinine. So you should be very, very careful about that. so that then can be double. Some of the anti-TB drugs are also hepatotoxic. So these are some of the precautions if you take. I think you can give, because both things cannot wait. But this will be, of course, little difficult issue. So both the the oncologist as well as the chest specialist, they should work in harmony to take care of these points. And regarding radiotherapy, of course, radiotherapy also is a immunosuppressed state. It can flare up. So one should be careful about that. Radiotherapist also use antiemetics and the same precaution, and also steroids sometimes to, particularly if it is a shear lung. Buccal mucosa will be a different issue. And now the techniques of radiotherapy has improved so that you can give pinpoint radiotherapy. It is no more a diffuse, so that other lung tissue are damaged. Only to the pointed area you can give radiotherapy. So it is the technical advantage now. So I think that should not be a big issue. The remaining part is when to go for surgery, because I think Ruchi very rightly said, when you are taking all precautions of infection control measures, the question is, as long as the patient is sputum positive. Here I could see that for about even till now, even if you have started, we don't have a sputum report. So if you are planning that way, I suppose the surgeon also will not be very comfortable to do in a case of sputum positive, particularly the MDR-TB. So it should be the OT accordingly. Infection control practices should be followed, and then separate table, patient should be kept separately. So all those precautions. And the other point will be main point, what will be the general anesthesia for this patient? Is she fit for general anesthesia? Suppose you go out for surgery, they're already lung damage, so you have to assess her general anesthesia as we usually do. The exercise, then the lung, the spirometry, diffusion, arterial blood gas, the way we do for any other general anesthesia fitness. That will be also another issue, just from the point of view of general anesthesia. So that precaution also, I'm sure. Then the question is how to, in a sputum positive. I suppose we should wait till the patient becomes sputum negative, but otherwise no surgeon will be taking up. I do not know Diwan if he is here. He can tell how, and Dr. Rupak is there, how they handle the sputum positive cases, the surgery, particularly lung surgery. But I think the general anesthesia principle will be the same. The patient has to be intubated. If necessary, she may go to the ventilator at least for some time. So I suppose these precautions have to be taken. So this is all about the cancer and the TB and the treatment part and their issues. The last part, I'll just be very brief, since already these points are taken up. Both Dr. Singla and Dr. Ruchi has taken up. I'm little perturbed about the getting a gene expert report. And I think I should be little blunt. Wherever, whether it is, I am not bothered whether it is UP, it is Chandigarh, it is Delhi. The point is, why a gene expert report 25/11, the patient got a smear positive, and then you got the 7/12, we were getting gene expert report. That means 2 weeks. That is just not acceptable. A 2-hour report should not be the program or the state, wherever it was done. They should be geared up, and I think that very mildly Dr. Singla had pointed out. Then my second concern was the fluoroquinolone. That that was sometimes in a past February 22. That means 7/12, that is 2 months. Why it should take 2 months to get that report? So it is only 25 is only 3 years away, less than 3 years away. And if we proceed this way, this should be a wake-up call. And we must insist on the program and the STO and the program managers. They should better manage this type of administrative issues, whatever may be the reason, I don't know. Then obviously the pre-XTR and XTR, they're telling, I do not know what the program, or maybe Dr. Singla will take up. Till how long will you wait for making a diagnosis of XTR? Bedaquiline and linezolid you have not done. it does not mean that it cannot be XTR. Even if you go to your previous definition of XTR, so here it is, resistance to both the fluoroquinolone as the second line injectable, right? So as per the old definition, it is XTR TB. Maybe it is a question of semantic. Now you have put the patient on treatment, and obviously I will also have the same concern about the why the patient is given levofloxacin. And then the third point is, and most important, why you are telling me the patient did not come up for follow-up. So you think that he has got still time to follow up. He's a type of patient. He needs special care. He has to undergo. So you have to get the report, what happened to his sputum, whether he's still smear negative, what is happening to him, and why not the DOT people or the people who are assigned this job, they should go to find out him. Why the patient should come? You should go and catch him wherever he is. इनका घर का address होगा, सब कुछ होगा, and I think that should be done. So these are, I'm sorry, I am little perturbed about that, about the management issue. Apart from the regimen is otherwise I think okay for me. The levofloxacin only, I have my objection with levofloxacin, that may not be warranted. So these are only some of my comments, but I should say the case was very nicely presented, and the expert, she made a very good review of literature. So thank you.
Thank you so much, sir, for your comments. Thank you, sir.
Thank you, Dr. Behra sir and Dr. Ruchi. Sir has very nicely summed up as to what all needs to be kept in mind while we are managing cases where there's malignancy and TB together. And sir, the points that pointed out, just I'll summarize them. He told us that we should be very careful when we are giving steroid to such patients, and when we are giving antacids like pantoprazole, when we are giving antiemetics, when there is autotoxicity, we should keep in mind that both type of drugs, some of the drugs can cause autotoxicity. And if the patient is being given radiotherapy, we should be again careful, because a patient may again be prescribed steroids and antiemetics. And sir also told us about when to go for surgery, preferably after sputum conversion. And then again, we have to keep in mind the pre-operative fitness issues that will be coming when we are working up those cases. So,
I want to make a point.
Yes, sir. Welcome, sir. Yes, sir.
Dr. Behra sir, actually, we had discussed earlier also that this statement, which is loosely given, that post-tubercular fibrotic scars lead to a greater incidence of scar carcinoma. But somehow, as both of us have seen in our experience, we have hardly seen any case. In whatever cases I have operated as thoracic surgeon, and you might have also seen, has there a study been done which has shown a greater incidence of scar carcinoma post-tubercular? Because this was a statement made in this course of this conversation. Sir.
Yes, you are right. Yes, you are right. Very right. I agree with you. Yes.
Dr. Rajendra Prasad, sir. Sir, unmute karna hoga.
Okay. Thank you, Neeta. And I must say, I have to offer two, three small comments. First thing that I must compliment Ruchi Dua. Fortunately, she has been my student for presenting a very good case and discussing also. The second point about the cancer and tuberculosis. We have little interest in, we have a lot of interest on TB, but we have little interest on cancer also. And so we have reported about 9 or 10 cases who are post-tubercular, but where there was a fibrosis after tuberculosis, at the same site, they have developed lung cancer. At least 4 or 5, I remember very vividly, and we have treated it also. And majority of them are adenocarcinoma, and some of them are squamous cell carcinoma. So that was the story about the scar cancer. But I agree with Dr. Behra, it's not very common, it's rare. I'm sharing my experience of last 45 years. Then the last point I would like to make, what Dr. Behra has said, I'm extending that point, that I am seeing the TB control program for at least for 45 years, 76 onward, when I was junior resident in Department of TB and Chest at KGMC. I used to say there's a lot of difference between science and the practice. Science in TB has gone far ahead. Everything is known, everything is possible. But you know, it's implementation. We used to say regularly every time, not today I'm saying, still there's a lot of problem in implementation. Whether it was TB control program in 62 to 92, whether it was RNTCP from 92 to 2019, or even the NTP from 2019 onwards. What I'm trying to say, as Dr. Behra said very rightly, we are just 3 years away of 2025. I think many of the STO has joined in this program. Many of the leaders of the TB control program of India must be listening. So we have to improve. The implementation, as you say, gene expert taking 2 weeks, second line LPA taking 3 weeks, and we listen cases after cases in this. Probably I am one who attended all the difficult to treat cases at national level, and most of the time we are very fond of shorter regimen. When shorter regimen is not being followed in strict rules, it says very clearly if there is a second line drug resistance to anyway, shorter regimen should not have been used. So actually what happens, if something comes new, always it gets a choice. So what I say that we have to be very careful. Otherwise, what we have seen from drug sensitive scenario to drug resistance scenario to even a bedaquiline resistance scenario. So unless we are careful in every case and we have to work on a mission mode, then possibly whatever our Prime Minister has a dream of 2025 of ending TB, we might reach to some near place to that. Thank you very much, Nita, for giving me opportunity.
Thank you, sir. It's always a pleasure to have you in our clinics and guiding us. Dr. Rishi, you raised your hand for quite some time. I'm sorry, I'm taking your question now.
Thank you, ma'am. Sir, I have a question to Behra, sir. Sir, if we will be giving this radiotherapy to this patient, so are there any chances of having fibrosis in the upper respiratory tract? And since patient is also a previous also has a history of smoking, so he might be harboring some part of COPD also. So in both the cases, if radiotherapy and the concurrent the background of the COPD is there, so are there any chances that patient might develop dyspnea in future after radiotherapy?
No, Dr. Saab, as I said, here it is a buccal mucosa, and with now the more advances with the exactly pinpointing, that is the the pinpoint. So obviously lung will be protected that in that sense. So I don't think there is any danger of developing post radiation pulmonary fibrosis, because they are not going to radiate the lungs. Here it will be only the buccal mucosa, and then they are now with the LINAC technology has now come, they exactly pinpoint and which will preserve even the surrounding area of that lesion. The so-called normal area is also protected. So I think, but I am sure that type of technology should be available. I'm sure Rishikesh, these are very common things, and they will be commonly available. And I know Rishikesh has got that machine, so that should not be an issue, Dr. Saab.
Thank you, sir.
Thank you, sir. Now, there's a question by Dr. Ruchi Madam. What is the optimal time for starting chemotherapy, that is anti-cancer treatment in this patient? So,
what is the?
would you like to what is the optimal time? When should we start the chemotherapy, the anti-cancer treatment in this patient?
No, I think it can be started as soon as possible, because if you can wait, it is okay. But if you want to start it, but maybe because the initially till you think the patient is stabilizing and he is well tolerating the drugs, because as I told you, the side effects will be, many of the side effects I had just enumerated, they may be common to both, particularly the GI side effects. The other things, liver, they are other things, but immediate problem will be the nausea, vomiting, which may be very severe with the platinum containing regimens. And if you give a sufficient amount of antiemetics, which are available now, very good ones, so then those side effects can be taken care of. So in that event, I'll say if by 1 week or 2 weeks the patient is stabilized with the anti-TB drugs, then only chemotherapy can be given simultaneously. We have done that, and patient have tolerated that also.
So, sir,
Thank you, sir.
around this issue, as you already said, even the review of literature does not say clearly when it should be started. Because as you said, through this clinic, can we take this consensus that first we start the anti-TB treatment?
Yeah,
for
sure.
2-3 weeks. By that time, the adverse effects of the anti-TB are tolerated, and the bacteria start getting killed by this good chemotherapy which we have nowadays. And then after 2 to 4 weeks, we can go for the anti-cancer treatment. So can we take the take-home message through this clinic?
Yeah.
Because
That is what I agree. And then, and the TT, of course, will be continued despite in addition to chemotherapy. In any case, we are not stopping a TT unless there are severe side effects. So that will be very difficult to predict. But I think very good antiemetics, judicious use of antiemetics should be there. The drugs for diarrhea, if we take care of that, and then of course there will be anemia, other parts, they will be taken care of. They are minor things.
Thank you, sir.
So are there any questions or comments?
Yes, I would like, if there is none from the audience, you see again as Dr. Bhera sir and Dr. Rendra Prasad, they also raised this issue of the delays. Like in this case, after the CBNet report was there, the sample itself for LP was sent after 2 months. You see, on one hand, we are thinking of starting the shorter regimen, and the sample for LP is sent after 2 months of CBNet, which should be sent the next day itself. Then the time between the shift of shorter injection regimen to oral regimen was 2 months. So this, because now the country has taken a call that there will not be an injection at any regimen. So all the patients, if we want to give shorter regimen, we will be giving the bedaquiline containing regimen. So in case we give bedaquiline containing regimen in a case where it should not have been given. So out of the 5 key drugs to be given, we have already used 3 drugs, that is bedaquiline, levofloxacin and propafol. So in a case where levofloxacin is resistant, we are going to develop resistance to bedaquiline as well as propafol. So I'm really worried about this state in the country that in case there are delays and we are starting the bedaquiline containing regimen without bothering about the LP or the LP being sent or LP report being collected. So as Dr. Rendra Prasad said in very clear words that we are heading towards augmentation of resistance in the country. To the good
Dr. Singla,
yes, sir.
Dr. Singla, can I just ask you for one clarification? During the, I'm sure everybody, the training course has again started, I was told.
Yes, sir, it has been started, and the NTI Bangalore has started, and even NITRD is planning to start the training again. It was done in a hybrid mode earlier.
No, but are these points highlighted to the doctors or those who are getting training? Why not these? I'm sure this will be part in the training module. They should be told 1, 2, 3. The patient comes, it should be done this way. So I think somehow this message is not going through very clearly. That is what. So I think that we need to know.
I think Dr. Sengsekharan is there. He can respond because his center is a training center at this moment.
Sir, thank you, sir. Sir, we have started the training, sir. Already 2 batches over, sir. Next week, 3rd batch is going on, sir.
Hello.
But as you told, sir, actually, whatever the training modules are there.
भाई अभी मैं class.
Somasekar, sorry, we lost you.
Unmuted, sir. Now am I audible, sir?
Yeah, now audible.
Sir. Sir, already 2 batches of DTO and starting, sir. Sir, during question and answers that we percolate these things, sir. However,
Yeah.
there is a need for revision of the module, sir. We are in the process, sir. Actually, we are in communication with the CTD. Certainly, we will take up that, sir. Thank you so much, sir. We will do, sir.
Somsekharan, I must say one more line. You know, mentor is a very important. Whosoever is giving training, he should emphasize very, very clearly that these things should not happen, because they are usually the program managers. They are the people who are going to manage. So I always say, student वैसे ही होगा जैसा mentor होगा. तो mentor का भी बहुत अच्छा होना जरूरी है. Mentor को clarity is very essential. So please see in the trainings, these things are very emphatically emphasized. Thank you.
Certainly, sir. That we are doing it, sir. We'll do it, sir. Thanks for the advice, sir. Thank you, sir. We'll take, sir.
Dr. Singla.
Yes. So, I mean, in the same case, again, after the patient was diagnosed as MDR TB, you know, to start the appropriate regimen, that is longer regimen, it took 3 months. So one can imagine that in case these delays are happening in the field condition, and I am sure they are happening, as sir said, in all the states throughout the country. So unless we take care of these delays in the sending the sample, delays in collecting the report, delays in taking action and starting the appropriate regimen, we are going to have more and more cases of drug resistance, even to the neo drug. So we should be very watchful for that. And plus, I think this was a very, very important case of cancer, whether oral cancer or lung cancer, along with TB. Dr. Ruchi did a very good job, and she really collected good literature on this. Although even after that, there are certain points which we have to take, so-called, like people like Dr. Behra, he has vast experience in cancer as well as in TB. So we can take their words that, okay, start with anti-TB drug first, and after 2 to 4 weeks, let him stabilize with the anti-TB drugs. Let him get accustomed to the adverse drug reaction, let the bacteria die, and then we can start this. And regarding surgery also, I like to have opinion of Dr. Diwan also, with a vast experience in managing the MDR TB cases by surgery, that how we are managing in our institute, the MDR TB cases.
Thank you, Dr. Singla. Thank you for asking me. See this, because I did not speak in between, because this case is a case of cancer tongue. And I suppose the ideal situation would be that a patient who has been put on correct treatment after doing all the culture sensitivities, correct anti-tubercular treatment, and if we have a possibility of being 5 to 6 weeks interval, that is an ideal situation. But suppose there is a risk of cancer getting upstage during that period, and we lose the chance of surgery being lost, that the patient goes into the stage when he no longer remains operable, then I suppose with adequate precautions, patient can be taken up for definitive surgery. As far as those cases who have lung cancer, in addition to drug-resistant TB, and if the disease is localized, I will definitely like that specimen itself is removed, that portion. But if there is a bilateral extensive disease with a malignancy in between, it will be very difficult actually to make that patient fit for surgery. So if they are, just as in this case, also there were lesions which are apparently on both sides of the lung. So those patients may not be fit for surgery. So an ideal situation would be a balance of the situation where we are able to put the patient on correct anti-tubercular therapy and the response starts coming. One thing which I want to make sure is that it is not absolutely necessary that patient should be sputum negative before surgery. Because in the modern day operation theatre technology, we can protect the personnel. The patient should be able to tolerate the surgery. That's most important. And it's because in a cancer surgery, it's an essential emergency surgery, almost semi-emergency. It should not be unnecessarily delayed for want of putting the patient on correct attitude. That's why. Thank you.
Diwan, as we are doing in our OT, if the country can afford, we should have few centers where there are laminar flows in the OT, so that MDR TB cases, whether with cancer or without cancer, they can be operated. So I think that can also be said here, because you already have your laminar flow in the OT. Is that
we have a laminar flow, and with COVID being as the COVID pandemic, most of the operation theaters started in laminar flow technology, because that was there in the COVID, in the peak of COVID pandemic, almost all surgery had to be stopped if those facilities were not available. And you could not stop surgical facilities for various conditions like cancer, cardiac diseases also. Also, I suppose there should be a minimal acceptable standards for operation theaters nowadays, where laminar flow, protection of personnel, HEPA filters, etc. They become a routine. Thank you.
Thank you, Dr. Divan sir. Dr. Katoch has joined us. Welcome, sir. Thank you, sir. If there are any comments or questions anybody would like to give? Dr. Katoch sir, would you like to give any comments on infection control practices for DRTB patients?
Sorry, Dr. Nita and Dr. Singla Saab, I'm very sorry to everybody because I couldn't stop in between the last my engagement, and I had a suspicion, but I missed most of it. But I'm very happy to see you all, and including seeing my senior, Dr. Ashok Bharadwaj is also there, Dr. Prasad also, and Divan Saab, everybody. So I think nice discussions, and I think when Dr. Vera was replying to the questions, this is a very eternal subject actually now, because I think what Dr. Divan, in the end, I listened to his comments, this situation will be there in number of places. When, of course, here the cancer is of another organ actually. If it is a cancer also of the lung also, then it's another complicated story, because then you are mixed up with the diagnosis. And this is the eternal story of more than 50 years back when we were in the medical college, the same confusion was there at that time also. So that is one issue. But the second part, which Dr. Divan, I was listening to him, that if you want to operate in such a case, which is positive, which is maybe likely to be drug resistant also, then the theaters now should be geared to take care of it, that because after COVID we have learned. And just changing the track, making the things in air safety procedures, the safety procedures for the other things, they're doable actually. So I think that fear was that don't do it at all and then delay for a couple of months. By that time, you're losing the person on account of the cancer. I think his comment was very, very valuable in the end. I think I'm very impressed with his comment. I think that's the only thing I'd like to say. But this is the time to change. I think I must say that part. This is a time to change for everybody, not to relapse back to what we were. Because COVID has taught us something to be better persons, survive and do better. I think that's one. Thank you very much. And next time, of course, I'll try to see I don't miss, because, the last meeting which I had, first meeting with your people, it was a great learning experience to me. So that I look forward to this meeting every, I think, then occasion for me not to give inputs, but to learn. So wish you good luck. Thank you. Yes.
Thank you. Thank you so much.
Vinita, one more point I wish to make. Recently, we had the visit of Director General Health Services, who is a physician and a renowned physician. He also expressed a desire that we should send him the link of this meeting. He would also like to join whenever he's free, depending upon his availability, and we may benefit from his experience.
We'll surely invite him, sir. Thank you, sir. At the end, we have Dr. Jha with us, who is the State TB Officer, Uttarakhand. Dr. Jha, if you could tell us the activities that are being done for echo sessions in your state. Actually, we had invited you earlier, but I think you could not join earlier. So I'm inviting you now for your comment.
Thank you, madam. Very nice, helpful, very nice session. We learning more. Very all the speakers are very well saying everything. Said about our eco in our state. The eco platform launched last month in our state. Training 5 session training done in our state, meeting 2 and 74 sessions of eco. Very useful for our STC. We learn more and more for session. Conduct training and meeting and record keeping for our STC and TV workers. Very helpful for us. Thanks our ECO. Thank you.
Thank you, sir. Thanks a lot. We've lost your voice, but I think is he speaking? Is he still speaking? Or? Okay. Thank you so much, sir, for your comments. And as we see, as you informed us that more than 74 sessions have been held in your state. So we hope to see more interesting cases from your state. And we'll be inviting you again, your state, for the case presentation. Thank you so much. Now I would request Dr. Ashok Bharadwaj, sir, who is the chairman NTF, to give his closing remarks and vote of thanks.
So thank you, Nita. So first of all, I want to welcome Dr. V.M. Katoch. So what I am today, I have learned a lot from him, and he was DG ICMR and Secretary DHR. So he helped me a lot during that period when I was at Dr. Rajendra Prasad Government Medical College, Tanda in Himachal Pradesh, and we did many research projects under his guidance. So thank you, sir, for that. Then Dr. Diwan, the other seniors, Dr. Behra. So Nita, I start. This is a case when it was presented in Uttarakhand, difficult to treat clinic. Dr. Singla was also there. So I also listened all the comments which were given by Dr. Ruchi Dua, and she had done a good homework. So thank you, Dr. Dua, and your team. So I welcome the comments given by Dr. Behra. I consider him one of the best national expert in TB cancer therapies. So thank you, Dr. Behra. I start from that because I told in that meeting also the turnaround time for LPA as well as for CVNet, and who is accountable then. So we must find somebody who is accountable, and we should know the reasons for this purpose. And we have the complaints from many places in the country where it is said in the clinic that the program, the net will take time, so you get the test from the outside, from the private sector. So patient has to pay for that. So we should look into that. And I raised the concern which was raised by Dr. Behra also. We have to see, program has to look into that, who is doing it and what should be the solution. So then it was wonderful case, and we should have these cases in future also, where each one in the country, each TB worker, the TB providing treatment to the patient who is benefited from the discussion at the national level and at the state level also. And one request I want to make to Dr. Nita also, because we are having wonderful cases, and if we can think of making a compendium of all these difficult to treat cases in our setup, and that will be good for all the postgraduate in the country doing post-graduation pulmonary medicine. So thank you very much. Thank you all who attended this. At one time, the attendance was more than 600, so 300, but it is still very less. But about 30% of what we expected. So I had given the mail to each one in the country, but hopefully in future, more people will join and will benefit by these difficult to treat clinic and the discussion thereof and the advice and the expert comments of all national experts in this field. So thank you very much. And I forget to thank Dr. Prasad also. So thank you very much.
Thank you, sir. Thank you so much. We have floated the poll. We request everyone to answer the poll. It gives us some insights into where we can improve. So kindly answer the poll. So thank you, Dr. Bharadwaj sir, Dr. Katoch sir, Behra sir, Dr. Somshekhar sir, Dr. Ruchi, Dr. Kuldeep Sajdeva sir, then Dr. Rajendra Prasad sir, all the seniors that we have, all the state TB officers, STDCs, district TB officers, faculty from medical colleges. Thanks a lot for joining. Thank you, Dr. Diwan sir, for constantly motivating us and to do better. Thank you so much. Thank you.